Fourniers gangrene was asked. This is pretty straightforward. It has been asked many times previously as well. Which of the following is not true regarding the condition shown in the image? They had shown gangrene in the area of the perineum. This is known as Fournier's gangrene. This is Fournier's gangrene, which is necrotizing fasciitis involving the perineal region. So testes are preserved. Yes, this is a correct statement. Because of dual blood supply, testes are usually preserved. It is common in diabetic patients. There is high mortality. Staph aureus is the causative organism. This is false. It is a synergistic infection. Synergistic infection means that both aerobic plus anaerobic bacteria are involved in this condition, and the mainstay of management is aggressive debridement. You have to cut the dead tissue. That is one of the mainstays of treatment. What is the initial management of a patient with benign prostatic hypertrophy with urinary symptoms? So any patient who comes with features of prostate enlargement and is diagnosed with BPH, initially we start with medical management, and the option given was prazosin, which is an alpha blocker. Medical management, alpha blockers are fast acting. 5-alpha reductase inhibitors can also be used. They are slow acting, but they have a more sustained effect. The example of 5-alpha reductase inhibitors is finasteride or dutasteride. Usually we use a combination therapy to start with, where we start an alpha blocker and a 5-alpha reductase inhibitor together. Surgical management, if it has to be done, we usually do a TURP, or these days lasers are also being used. The most common laser is ND-YAG. The best laser is KTPA, green light laser. Which of the following, all of the following are true regarding nephroblastoma? So this was a question regarding Wilms tumor. It was very surprising. There was one question regarding Wilms tumor, and there was one question regarding renal cell carcinoma, also bladder carcinoma. So one of the themes in this time's exam, lots of questions regarding cancers and their management. So up till previously in the FMG exam, such in-depth management of cancers was not being asked. So, definitely they are raising the standards, and you need to have more in-depth knowledge of surgery to answer these questions. So if you've seen the Marrow videos, all this is covered, but from the FMG perspective, everyone was being very selective because they were mostly asking those topics. This time, of course, they've bowled a googly or a bouncer, and many more topics and tough questions have been added. All of the following are true regarding Wilms tumor except hematogenous spread is correct. That is why lung metastasis, it is the most common site of metastasis. Treatment is chemotherapy followed by surgery. This is also true. There are two ways to proceed in Wilms tumor. You either do surgery first followed by chemo, or you do chemo followed by surgery. And one main difference between Wilms and renal cell cancer is that Wilms is chemosensitive, whereas renal cell cancer is not chemosensitive. It is chemo and radio resistant. RCC is chemo and radio resistant. It is the most common intra-abdominal malignancy in children. This is wrong. Most common pediatric renal malignancy. It is the second most common abdominal malignancy in children, most common being neuroblastoma. Patient comes with a mass and hematuria. There are three syndromes which can be associated with Wilms tumors. You have Beckwith-Wiedemann, Denish-Drash, or Vagar syndrome. There are two stagings. You don't need to know the stagings in detail. National Wilms tumor staging or the Society of International Pediatric Oncologists. Just one thing which is unique in Wilms tumor staging, there is a stage 5 which you will not see in other tumors. Stage 5 is bilateral Wilms tumors. So this was another question from urology. A 44-year-old female with a flank mass which is ballotable. We know renal masses are ballotable, kidney masses are ballotable, and the mass measures 4 centimeters on a CT scan. Urine shows malignant cells. What is the management? So you have malignant cells in the urine and mass is 4 centimeters. So we are dealing with a patient with renal cell cancer, we know T1 is less than equal to 7 centimeters. Okay, and for T1 tumors we can do partial nephrectomy. We don't need to do radical nephrectomy. If it is beyond T1, if it is T2, T3, T4, then we will think about doing radical nephrectomy, but for T1 we can do partial nephrectomy or nephron sparing surgery. That will be the correct answer. So very simple, T1 less than 7 centimeters, or if it is a bilateral renal cell cancer, then we do partial nephrectomy, otherwise radical nephrectomy. 55-year-old male is diagnosed with left testicular carcinoma. Which of the following lymph nodes is the first to be involved? The option number A they had given was inguinal, and this was to confuse students. This we've discussed many times, that testicular cancers, they don't go to the inguinal lymph nodes first, they go to the para-aortic lymph nodes, right? Because that is where the testis develops and then it comes down into the scrotum. So the first echelon or the first draining lymph nodes are the para-aortic lymph nodes. Now again, they had made it very tricky. You need to know that from left testis, the first drainage site is to the para-aortic lymph nodes, which is the correct answer. But if right testis was asked, then it would have been inter-aortocaval, means between the aorta and the IVC. So these are lymph nodes around between the aorta and the IVC, whereas left testis goes to lymph nodes which are around the aorta, para-aortic lymph nodes. So this you should be aware of. Which of the following will not have bilateral hydronephrosis? We know hydronephrosis is dilatation of the pelvic-calyceal system, that is known as hydronephrosis. Now, if you remember the lectures, I've told you that any cause which occurs before the opening of both the ureters will lead to unilateral. So anything which goes wrong here, here or here will give rise to unilateral. But any cause which occurs after both the ureters have opened up, that will cause bilateral hydronephrosis. So anything here, here, here will cause hydronephrosis on both the sides. Now let's see. Phimosis means there's inability to retract the foreskin. So that will give rise to bilateral hydronephrosis. Okay, that is going to give rise to bilateral because it is distal to the opening of both the ureters. Similarly, posterior urethral valve also bilateral hydronephrosis. Urethral stricture also bilateral hydronephrosis. Retrocaval ureter is only seen on the right side. Retrocaval ureter means that the right-sided ureter goes behind the IVC. That is retrocaval ureter. So the correct answer is retrocaval ureter, which will give rise to unilateral hydronephrosis. There was another question regarding ureterocele or cobra head or adder head appearance. This is a previous year question which has been asked many times in the exam. This is a retrocaval ureter only on the right side, and you get a reverse J or fish hook sign. That is the sign which you will see. Posterior urethral valves, bilateral hydronephrosis, and you will get a keyhole defect. You get a keyhole defect on micturating cystourethrogram, or on ultrasound you get a keyhole defect. There was another question regarding ureteric stones. They had shown an X-ray KUB. KUB is kidney urinary bladder. X-ray they had shown, and they had shown stones in the ureter, and they had asked, how do we manage stones in the ureter? ESWL is extracorporeal shock wave lithotripsy. This is done for stones which are there in the kidney. PCNL is percutaneous nephrolithotomy, again done for stones which are there in the kidney. Wait and watch is for stones which are less than equal to 5 millimeters in size. They had not mentioned the size, so the correct answer will be URS. URS is ureteroscopic removal of stones. That means you put a scope in the ureter and then you go and catch the stone. So ureteroscopic removal of stone is the correct answer. URS is what is done for ureteric stones. This was a straightforward question. They had shown a CT of a patient with an abdominal mass, and you could see that the kidney was fused, the lower end. This is horseshoe kidney. Horseshoe kidney is when the lower end is fused and the ascent is restricted by the inferior mesenteric arteries. The fused portion usually lies at the level of L3. Adrenals are in the normal position, and we never cut the fused portion. On intravenous urogram, you will get a flower vase sign or a handshake sign, and the patient usually comes with an abdominal lump. So like I said, there was a question regarding testicular cancer, bladder cancer, renal cancer, Wilms tumor. So 4 cancer questions just from urology they had asked, which was quite surprising. A 70-year-old male presents with painless hematuria. He is diagnosed to have bladder cancer invading the muscle layer. What is the management? So we know bladder cancer can be divided into superficial bladder cancer. Superficial bladder cancer is above the muscle layer, and if it is above the muscle layer, we will do TURBT. TURBT is transurethral resection of bladder tumor. TURBT, transurethral resection of bladder tumor. Plus we will do either intravesical chemo, means we are going to give chemo inside the bladder, or intravesical immunotherapy in the form of BCG. Yes, BCG, which is the tuberculosis vaccine. But this is for superficial bladder cancer. So that is why these 2 options were out. Now, advanced bladder cancer is when the muscle layer is invaded. When the muscle layer is invaded, we either have to do a partial cystectomy or a radical cystectomy. And when we do a radical cystectomy, the prostate is also removed. Now, because the option of partial cystectomy was not there, the correct answer here is going to be cystoprostatectomy, or in other words, a radical cystectomy. So these were the questions regarding urology. Moving on to vascular system, there were 4 or 5 questions from vascular system also. Which of the following is the gold standard in the management of varicose veins? So these days, varicose veins, gold standard for varicose veins, we are using either RFA, which is radiofrequency ablation, or we do EVLT, which is endovenous laser therapy. These are the 2 surgical options which are the gold standard for varicose veins. They had given radiofrequency ablation, and that is the correct answer. Some students said that radiofrequency ablation was not given. The term thermal ablation was given, which is also the correct answer, because thermal ablation includes both radiofrequency and laser ablation. Sepsis, subfacial endoscopic perforator surgery, we usually are not doing this. Stripping and ligation is usually out these days. So the best treatment is radiofrequency ablation. A 65-year-old male presents with multiple episodes of painless hematuria. He has a blottable mass in the left flank. No WBCs are seen in the urine. Most likely diagnosis. So an elderly male coming with painless hematuria and a blottable mass in the left flank means a renal mass. This is renal cell carcinoma. Hematuria is the most common clinical feature of RCC. Pain and mass are the other clinical features. This typical triad is seen in 15% patients. Only seen in 15% patients. The most common symptom is hematuria. Paraneoplastic syndromes are also common in RCC, and the most common is raised erythrocyte sedimentation rate. These are the other paraneoplastic syndromes. You really don't need to remember them for the FMGE exam. Whether you want to call this a surgery question or a pathology question, the details regarding the types of RCCs are also usually asked. Which of the following statements are true regarding clear cell carcinomas? They contain glycogen and lipid. This is a true statement. Mostly sporadic. This is also true. They occur due to deletion of chromosome 3q. This is false. They occur due to deletion of 3P and not 3Q, and they arise from PCT, proximal convoluted tubule, and not distal convoluted tubule. So 1 and 2 are the correct statements here which you need to know about. The most common type of RCC is clear cell. There is deletion of 3P and 6P. It can be associated with VHL, that is von Hippel-Lindau syndrome, but most of the tumors are sporadic in nature. They arise from the proximal convoluted tubule. Papillary renal cell cancers, hereditary papillary RCC syndrome can be there, but again mostly they are sporadic. You can get Samoma bodies, this has been asked, and again mostly they arise from the proximal convoluted tubule. They can be associated with long-term dialysis therapy. Chromophobe type of RCC has the best prognosis, and this is the question which has been asked in the FMGE exam. They can be associated with Birt-Hogg-Dube syndrome, and you can get plant-like cells and raisin-like nucleus. This is the slide which you can see. The slide has not been asked in the FMGE exam. A 47-year-old man presents with a renal mass involving the lower pole measuring 7 into 4 into 2 centimeters. What is the preferred treatment option? So this is T1 disease. Now you need to know that renal cell cancers mostly occur in the poles. Superior pole is the most common, followed by the inferior pole. And T1 is up till 7 centimeters. So if you have a single lesion in the poles up till 7 centimeters, you can carry out a partial nephrectomy. You don't need to carry out a radical nephrectomy. Also, you should know that renal cell cancers are chemo and radio resistant tumors. So surgery is the mainstay of treatment in renal cell cancers. The indications for partial nephrectomy, you have T1 tumors restricted to the poles, if you have bilateral renal cell cancers or renal cell carcinoma in a solitary functioning kidney. The relative indications are RCC in a kidney where the other kidney is affected with hydronephrosis or stones. But these 4 indications you should definitely remember for partial nephrectomy. Invariably, there is one question from renal stones. In the last 3 FMG exams, renal stone questions have been very common, so you should know about renal stones. The most common type of renal stones are calcium oxalate stones. So calcium oxalate stones are the most common. They are radiopaque and they are found in acidic urine. Calcium oxalate monohydrate stones are very hard stones. We also call them dumbbell-shaped crystals. Triple phosphate or struvite or staghorn calculi is calcium, magnesium, ammonium phosphate. They are formed in alkaline urine, which is usually infected due to Proteus, and this has also been asked in the exam. These are also radiopaque and they can grow up into large stones before they become symptomatic. Cystine stones are very hard stones. They are the hardest stones and they have a crystalline lattice. They are formed in acidic urine. Uric acid stones are radiolucent. They are the most common radiolucent stones and they can be seen in gout and tumor lysis syndrome. So calcium oxalate crystals can be envelope shaped or dumbbell shaped. Uric acid are like glass shards, all shapes and sizes. Struvite stones are like coffin lid crystals, and cystine stones you have crystalline lattice. This is again a very frequently asked question, almost been asked 3 times in the FMG exam. A 5-year-old girl comes with continuous dribbling of urine with normal voiding pattern. What is the most likely cause? So there is continuous dribbling also and she can hold also. So this occurs when there is duplication of the ureter and one of the ureters is opening in the ectopic position. So this is duplication of the ureteric system. This is known as Weigert-Mayer's rule, where one of the ureters, which is usually draining the upper pole, it opens distally and ectopically. So in females, it will open in the vagina, which is why the girl is having continuous dribbling, because there is no control. If urine goes in the vagina, there is no control there. You can't stop it. And because one ureter is going in the bladder, there is control also. So normal voiding pattern plus continuous dribbling. This is the telltale sign of duplication of the ureteric system. Whitaker test, this is just a factual question which has been asked once. It is done in hydronephrosis. Imaging of the renal tract is done and it is shown below what is the likely diagnosis. So here you can see a kidney where there is calcification. So such a calcified kidney is known as a putty kidney, and this is seen in tuberculosis of the kidney. So in tuberculosis of the kidney, you can get putty kidney and cement kidney. Putty kidney is when there's pus and cement kidney is when it becomes calcified. These are the changes which can occur in tuberculosis. You should also know that the earliest change in renal tuberculosis is a papillary ulcer. One more question which was asked 3 years back in the FMG exam, that tuberculosis of the genitourinary system can even give rise to a golf hole ureteric orifice, means the ureteric orifice remains open. And if the ureteric orifice remains open, it leads to reflux. Okay. This is a perinephric abscess which you can see. This is renal tuberculosis. This image has been asked many times in the exam. Image of a newborn child is shown. What is the likely diagnosis? This is ectopia vesicae. In the previous video, in part 3, I've already told you about omphalocele and gastroschisis. They are also frequently asked. So you can look at the third part on my YouTube channel where you can know more about omphalocele and gastroschisis towards the end of the video. Here you can see that the bladder is exposed. The anterior abdominal wall is deficient below the umbilicus and the bladder is exposed. This is ectopia vesicae or bladder extrophy. This was asked in a recent exam. A 35-year-old male comes to the OPD with right flank pain. CT image is shown, which is incorrect statement. So you can see these multiple cysts in the kidney, right? So this is because of echinococcus infection, right? Echinococcus infection has caused this, or it has given rise to a hydrated cyst in the kidney. So albendazole should be given. This is true. It is caused by tapeworm. Leakage of cyst can cause anaphylaxis. FNAC should never be done prior to surgery, because if FNAC is done, it can give rise to spillage. So this is caused by Echinococcus granulosus, not caused by dog tapeworm, and we don't do an FNAC prior to surgery. A child is brought to the clinic for evaluation of recurrent UTI. Intravenous urogram is shown. So these images are very important. This is your inverted Lilly sign, right? Inverted Lilly sign, and this is also seen in duplication of the pelvic system. In horseshoe kidney, here you can see duplication of the pelvic system. Here you can see and horseshoe kidney, what will you see? Horseshoe kidney, we will see a flower vase sign. We see a flower vase sign in horseshoe kidney, and horseshoe kidney, you should know that it is usually fused at the level of L3 and L4. It is the inferior mesenteric vessels which prevent the ascent of the kidney, and we should never resect the fused portion. So you can see a horseshoe kidney here. Both the lower poles are fused. All patients should undergo resection of the fused portion. That is false. Majority of the patients are asymptomatic and incidentally detected. Adrenal glands are not on the ectopic location, and inferior mesenteric arteries restrict the ascent of the kidney. This is also true. Okay. So 20-year-old male presents with sudden onset pain in the right inguinoscrotal region. On examination, the right side is higher up in position and tender on palpation. What is your diagnosis? So you have a young male with sudden onset right inguinoscrotal pain. The testis is higher up in position and tender to touch. These are all signs of testicular torsion. Why isn't it epididymoarchitis? Because if it was epididymoarchitis, lifting of the testis would have reduced the pain, right? Whereas in torsion, if you lift up the testis, it increases the pain. So to differentiate whether it is epididymoarchitis or torsion, there are clinically 3 signs which can be done. Pren sign, if you lift the testis, pain reduces in epididymoarchitis, it increases in torsion. Angel sign is a transversely placed testis in torsion, and Deming sign is that the testis which has undergone torsion lies at a higher level. A patient working in the dye industry presents with bladder cancer. Again, a very common question. This is transitional cell carcinoma. In bladder, transitional cell carcinomas are the most common. And you can remember the risk factors as 3 C's: cigarette smoking, chemical dyes, and cyclophosphamide, which is an anti-cancer drug. Squamous cell carcinoma, you can remember the risk factors as 2 S's: schistosomiasis and smoking, and this is usually seen in African countries. Again, bladder cancer patient is going to come with massive hematuria. That will be the most common presenting feature. A 10-month baby is brought to the hospital by his mother. His right testis is in the inguinal region, whereas the left testis is in the perineum. What is the diagnosis? Now, they have twisted this question over the last 2 years and they've asked it repeatedly. So, undescended testis, ectopic testis is extremely important for the FMG exam. So, because the right testis is in the inguinal region, it is an undescended testis. But left testis is in the perineal region. It is deviated from the normal path. So the left testis is going to be an ectopic testis. So what we are dealing with here is right undescended and left ectopic testis. So undescended testis, when it is arrested along the normal path, and the most common site is the inguinal canal. But if it deviates from the path, we call it an ectopic testis. And the most common site for ectopic testis is the superficial inguinal pouch. So please don't make this mistake. You have to read carefully. If they ask ectopic, then it is superficial inguinal pouch. Whereas if they ask undescended, it is the inguinal canal. A 5-month baby is brought to the OPD with bilateral undescended testis. Now, bilateral undescended testis is known as cryptorchidism. What should be done? So if there is cryptorchidism, there is a role of giving GnRH injection. A single GnRH injection should be given in these patients. And if after giving the GnRH injection, if till 6 months of age, if the testes don't come out, then we will carry out orchidopexy. Okay, so we wait till 6 months for spontaneous descent, but in cases of bilateral undescended testes, we will give a GnRH injection. 40-year-old male comes with a testicular swelling and another swelling over the umbilicus and in the right supraclavicular region. What is the most likely diagnosis? So this is a testicular tumor because there is a testicular swelling above the umbilicus are retroperitoneal lymph nodes, and you can have supraclavicular lymph nodes as well. These are all signs of a testicular tumor. Testicular tumors, you should always remember, we never do FNAC or biopsy in a patient with suspected testicular tumor. Again, Fournier's gangrene, last 3 years, 3 exams of FMG have asked this. You should know about this. Elderly male with sudden onset pain in the scrotum and discharge. Based on the image shown below, this is Fournier's gangrene, which is a necrotizing fasciitis involving the perineal region. It is usually a mixed microbial infection, that is aerobic plus anaerobic. We also call it synergistic gangrene. It is usually seen in immunocompromised patients, and the treatment is aggressive debridement and broad spectrum antibiotics. You can see here the testes are usually spared because the testes have dual blood supply. Torsion, I have already told you, the risk factors are bell clapper testis, inversion, undescended testis, and cyst of Morgagni. And I have told you the clinical signs of how to differentiate torsion from epididymoarchitis. A male patient comes with painless enlargement of the testis. LDH values are raised. What is the next step in management? I told you painless enlargement of the testis, we should always suspect a tumor, and there are 3 tumor markers in testicular tumors: LDH, beta HCG, and alpha fetoprotein. These are the 3 tumor markers which we measure. So here the LDH values are also increased. Like I said, we never do FNAC or biopsy, because in suspected testicular tumors, if you do an FNAC or biopsy, that can upstage the tumor. It can cause spillage of the tumor. So in suspected testicular tumors, we carry out high inguinal orchidectomy. Please don't make a mistake in this. This has been asked many times. It's a trick question. They want you to mark FNAC, which is why FNAC will always be as option A. What you have to do here is high inguinal orchidectomy. So this is the staging of testicular tumors. You don't need to remember the staging for your exam. You should just remember the 3 tumor markers which are there in testicular tumors. A young male comes with dull dragging pain in the scrotum. On examination, bag of worms consistency is palpated. So bag of worms consistency is characteristic of varicocele, which is nothing but dilated, tortuous, pampaniform plexus of veins. So dilated, tortuous, pampaniform plexus of veins is varicocele, and varicocele is a common cause of male infertility. It is a common cause of male infertility which you should know about. Hydrocele, you will get fluctuation and you can get transillumination. It is accumulation of fluid in the tunica vaginalis, and fluctuation and transillumination can be seen in hydrocele. 50-year-old male felt heaviness in the scrotum. You're suspecting a cancer. Transillumination test is negative. No pain. What is the diagnosis? So it is a tumor, and if it is a tumor, we have to, like I said, high inguinal orchidectomy has to be done. So this question I've already covered. Old man with metastasis in the vertebrae and bones. Old man with the mets in vertebrae and bones, it is most likely to be prostate cancer. Had this been a female with mets in the vertebrae and bones, we would have marked breast cancer. Here it is prostate cancer. You should know that prostate cancer mets most commonly to the lumbar vertebrae. They are osteoblastic, more common than osteolytic. So blastic means bone forming more than bone destroying. And this question has been asked, that how do these metastases or how do these cells reach the vertebral column? So they reach the vertebral column because of the Batson's plexus of veins. You should be aware of this. An elderly male is detected with carcinoma prostate. On evaluation, metastasis is found. Which of the following drugs is used in this patient? So like breast cancer, where if ER/PR positivity is there, we use hormonal therapy to block the hormones. Similarly, prostate cancer is also driven by testosterone. So in males who have metastatic prostate cancer, we can use androgen depletion therapy, ADT. We have to reduce the level of androgen, and we can do that by using leuprolide. Right, so metastatic cancer, orchidectomy, or we can use LHRH agonists like goserelin or buserelin or antiandrogens. Hormone resistant patients, we can use chemotherapy, radiotherapy. Siplucil T is a T cell vaccine, or we can use radiopharmaceutical therapy which acts via alpha rays. This was asked last year. Which grading system is used for prostate cancer? We use the Gleason's score for prostate cancer. Which isotope is used for treating or giving radiotherapy? It is iodine 125. Iodine 125 seeds are used in giving radiotherapy in prostate cancer. Iodine 131 acts via beta rays, and this has a half-life of 7 to 8 days. This is used for thyroid cancer treatment. This I've already told you in the second video which is there on my YouTube channel. In the last 3 years, 2 questions have been asked regarding these RGU and MCU. So this is a simple question: urethral trauma. Mother gets a child to the urology OPD complaining of difficulty in passing urine since a few months. Urologist orders a test which shows the image below. What is the investigation? Okay, so you can see here you can see that dye has been injected from outside and it is going in. You can see dye is injected from here. It is going in. So this is an RGU, retrograde urethrogram. What is RGU? Retrograde urethrogram. When we push in dye from outside and it goes in. If dye was already in the bladder and then it comes out, then it is called an MCU, micturating cystourethrogram. But for suspected urethral trauma and to visualize the anterior part of urethra, we do an RGU. Urethra, there are four parts. You have penile urethra, bulbar urethra. Penile and bulbar commonly are known as the anterior urethra, and the prostatic and membranous are known as the posterior urethra. Okay. A patient presents with hernia medial to the inferior epigastric artery. What is the most likely diagnosis and the management? This was asked last year. So medial to inferior epigastric artery, it is direct hernia, and we will do a Lichtenstein's tension-free mesh hernioplasty. The boundaries of the Hasselbalch triangle have been asked many times. So Hasselbalch triangle is bounded by the outer border of rectus, inferiorly by the inguinal ligament, superiorly by the inferior epigastric vein. Any hernia which lies lateral to it is indirect, and any hernia which lies medial to the inferior epigastric vessels or inside the Hasselbalch triangle is a direct hernia. Irrespective of whether it is direct or indirect, we do a Lichtenstein's tension-free mesh hernioplasty. Which of the following does not form boundaries of the myopectineal orifice of Frouchard? So arching fibers of internal oblique form the superior boundary, iliopsoas forms the lateral boundary, Cooper's forms the inferior boundary. Inferior epigastric vessels are not a boundary. The medial boundary is formed by the outer border of rectus. By the outer border of rectus. Right, triangle of doom and triangle of pain have also been asked many times. Which of the following does not form boundaries of these triangles? So vas deferens does. Peritoneal reflection, gonadal vessels. Cooper's ligament does not form a boundary of these triangles. Triangle of doom is bounded by the vas deferens medially, testicular vessels laterally, and the peritoneal reflection inferiorly. This lies medially, and external iliac vessels and the genital branch of genitofemoral nerve lie in this triangle. Laterally lies the triangle of pain. You have the triangle of pain, and here three nerves, lateral cutaneous nerve of thigh, femoral nerve, and femoral branch of genitofemoral nerve lie here. The most commonly injured nerve or entrapped nerve during laparoscopic surgery is lateral cutaneous nerve of thigh, and this can give rise to a symptom complex known as meralgia paresthetica. The significance of these two triangles is that in these two triangles, we should not put a stapler or suture because we can injure these structures. So, patient underwent inguinal hernia surgery and there's sensory loss in the root of the penis and scrotum. Which nerve has been likely injured? It is the ilioinguinal nerve. During open surgery, ilioinguinal nerve is the most commonly damaged nerve. This I had already covered in the previous video. This is congenital diaphragmatic hernia, which is also very important. And in the previous video, I've told you the most common type of congenital diaphragmatic hernia is Bochdelic hernia, which is left posterolateral. Morgagni, on the other hand, is right enteromedial, right? Patient usually dies because of pulmonary hypoplasia. That is the leading cause of death in these children. So these are the questions regarding urology and hernia. I've covered all four parts, entire surgery in a nutshell. These high yield topics are there. Please watch these 4 videos before your FMG exam. Also, my advice, in the last 10 days or so before your exam, every day 2 to 3 hours, just watch the recall videos of previous years. So at least last 2 to 3 year recall videos of all subjects you should watch. If you can do those thoroughly also, you will be in a very good position to clear your exam. All the very best. See you on the other side. Thank you. Starting with the questions which are asked in general surgery. So, which is not a component of the Q-SOFA score. Now, Q-SOFA score has been asked previously. This is a question which has come in INI CET many times and once in the FMG exam as well. Now, Q-SOFA is Quick Sequential Organ Failure Assessment Score, and we know it includes altered mental status, systolic BP less than 100, and respiratory rate more than 22. What is not included is serum lactate is not included. This is not a part of the Q-SOFA score. This is the Q-SOFA score, the Quick Sequential Organ Failure Assessment score, and you can see I've told you the parameters: hypotension less than 100, altered mental status, and tachypnea more than 22. Each value is given a score of 1, and if the score is 2 or more than 2, that is associated with a poor outcome. This was also a previous year question, a straightforward question which was asked. I asked you to identify the instrument, and this is a linear stapler. A linear stapler is used for resection and anastomosis of bowel, resection and anastomosis. One previously, this has also been asked for Zenker's diverticulum. It is also used for Zenker's diverticulectomy. We use a linear stapler. This one is a circular stapler, and circular staplers, the most common use of a circular stapler is stapler hemorrhoidopexy, which is the procedure of choice for hemorrhoids these days. So stapler hemorrhoidopexy, which is the procedure of choice for hemorrhoids, we use a circular stapler there. This is again a concept which has been asked many times in the FMG exam. They had shown an image of a patient with a split thickness skin graft being raised. Now, the most common donor site, is the thigh of the patient, and the graft is put on the same patient, right? So what kind of a graft would this be? This would be an autograft. Autograft is when you take some structure and you put it on the same patient. That is an autograft. Isograft has been asked many times. It is when grafts are exchanged between identical twins. Allograft is same species. So supposing you're taking the kidney from one individual and giving it to another individual, that classifies as an allograft. And a xenograft is from different species. You must have heard recently that a pig heart was transplanted in a human. So that classifies as a xenograft. So these definitions are a frequent part of the FMG exam, and you should be aware of them. This was an easy question. A soldier with injury to the leg develops extreme pain and crepitus at that site. Which of the following is the causative organism of gas gangrene? So they had given a history where they had said that a soldier sustains an injury. There's extreme pain and crepitus. Crepitus would only form when there is gas. So some students were saying that they did not mention gas gangrene. They had just given this stem. So if they had given this stem just on the basis of extreme pain and crepitus, you can make the diagnosis of gas gangrene. Now gas gangrene, occurs because of Clostridium perfringens. So this was a straightforward question. There were two questions from shock which were asked. And one of the questions is from hypovolemic shock, which is always asked in the exam. This one was a new question where they had asked which of the following is seen in all types of shocks. There are various types of shocks. You have hypovolemic, cardiogenic, distributive, septic shock. But one common theme amongst all shocks is that the tissue is receiving less oxygen, right? That is a common theme around all shocks. And what we were taught in physiology is that shock is hypoxia at the cellular level. So the common theme is going to be decrease in tissue perfusion. That is what is seen in all types of shocks. A patient is brought to the emergency room after road traffic accident and vitals point towards shock. The urine output is decreased. Patient appears to be confused. Right? From which stage of shock does urine output start reducing? Now this was a tricky question. This was based on this table which is there of hypovolemic shock, which I've highlighted umpteen number of times that there is invariably a question which is asked from this table. And you know there are four classes of hypovolemic shock. Class 1 is when the percentage of blood volume loss is 0 to 15%. There is no change in the vitals here. Class 2 is when the heart rate is increased, there is tachycardia, but this is compensated shock, and urine output can start reducing here. Okay. Can start reducing, but the systolic BP remains normal. That is why we call it compensated, because despite the blood loss of 15 to 30%, the systolic BP remains normal. Class 3 is when the systolic BP starts to fall. This is 30 to 40%. Of course, there will be decreased urine output here as well. And class 4 is when the vitals are not palpable. I mean, the pulse is not palpable, the BP is not recordable, the vitals are not recordable. So these are the four classes of shock. The question here was, from which class does urine output start to reduce? So it starts to reduce from class 2, which is going to be moderate shock. So moving on to the questions pertaining from breast, thyroid, head and neck and endocrine system. There were at least 7 or 8 questions from these topics. Breast is usually asked quite a lot in FMG exam, and this time also there were 4 questions, although the difficulty of 2 questions was quite high. And one of the questions was recently asked in the super specialty exam as well. So that was the level of questions which was being asked. So most important risk factor for acute mastitis. We know breast abscess is a very common topic which is asked in the FMG exam, and the harbinger of breast abscess is a cracked nipple, and through that cracked nipple, Staph aureus, which is the most common organism, that enters the breast and causes the infection. So cracked nipple is the cause of acute mastitis. This was a repeat question. Peau d'orange or orange peel appearance has been asked many times in the exam, and they had asked what is the cause of the condition which is shown. So it was an image of peau d'orange. To confuse students, they had given superficial lymphatics and deep lymphatics. Now we know that peau d'orange occurs because of the involvement of subdermal lymphatics. So subdermal lymphatics are superficial lymphatics, which is going to give rise to PD or peau d'orange appearance, and this includes involvement of the skin. Dimpling is another sign, which is because of ligaments of Cooper involvement. Retraction of the nipple is because of lactiferous ducts. It can be circumferential, which is usually seen in cancer, or slit-like, which is seen in ductictasia. Peau d'orange is orange peel appearance due to subdermal lymphatics. Now this was the question which was asked in one of the recent super specialty exams. Mutation in BRCA gene should be checked in which of the following patients except. Now patients who have male breast cancer, bilateral breast cancer, breast or ovarian cancer, or they have a strong family history of breast and ovarian cancer, or if the patient is less than 40 to 45 years of age, that means a young patient with breast cancer, those are the patients where we check for BRCA mutations. So the exception here is a patient who is more than 50. That is not the correct answer. So if you look at the indications, right, you will have a BRCA mutation already in a first degree relative. If you have bilateral breast cancer, triple negative breast cancer, male breast cancer, or if there is early young patient with breast cancer, that means breast cancer less than 45 to 50 years of age, that is when we check for BRCA mutation. We don't check it in all the patients. This was also a tricky question. We know that staging of breast cancer is usually asked in the exam. Breast and oral cancers are the two stagings which are frequently asked in the FMG exam. But the twist were the prefixes which they had used. So you had a 51-year-old female who was complaining of a mass in the right breast. The mass was ulcerated, ulceration was shown, discharge was shown, and the mass was more than 2 centimeters and lymph nodes were present. The mass was not fixed to the skin. Now this is something which the students have said, but if ulceration was there, I think so this statement wouldn't have been there. Okay. Now they are asking the stage. So we know this prefix of C means clinical staging. That means when we examine the patient and then we conclude the staging, that is known as clinical staging, and we write C, T, whatever, N, whatever, and M, whatever. Here, because the skin is involved, we know it is T4. We know it is T4, and T4B is involvement of skin. If PDO, puti orange, is present in more than 1/3 of the breast, then it would be T4D or inflammatory cancer. Okay. N1 because the lymph nodes are enlarged, and M0 because no mets are present. So this was the correct answer, C, T4N1 M0. Now what does Y mean? Y, I have told you, if you've seen my videos, I've told you why we write when the staging is done after neoadjuvant therapy. If we do the staging after neoadjuvant therapy, that is when we write it as YTNM. Okay, so supposing the patient has received some form of chemotherapy or hormonal therapy, and then we do the staging, then we will write it as Y staging, YT3N1 or YT2N1. Here nothing of that sort was mentioned. That is why Y options got eliminated, and because ulceration was there, it was easy for you to mark. So if you knew this concept of C and Y, it was an easy question. Otherwise, a tricky question for the FMGE exam. Moving on to the questions regarding thyroid, parathyroid and endocrine system. There was a patient in which recurrent kidney stones and psychiatric symptoms with fatigue was present. Which investigation will be used for the diagnosis? And they had shown an X-ray of the hand which was showing features of hyperparathyroidism. Now, hyperparathyroidism, you know the clinical features are bone stones and abdominal groans. That is the mnemonic: bone stones, abdominal groans. In bones, you can have brown tumors, you can have subperiosteal bone resorption, more on the radial aspect, salt and pepper skull, right? So you can see subperiosteal bone resorption, you can see these brown tumors, and you can even see salt and pepper skull. So these are the bony findings. You can get multiple or recurrent renal stones, which is the most common finding. There can be abdominal pain due to pancreatitis as well, and there can be psychiatric symptoms. So when the patient is showing features of hyperparathyroidism, of course we will do serum PTH to see if PTH is raised or not. Okay, PTH should be raised here. But to see whether this is due to an adenoma or it is due to hyperplasia, we will do a sestamibi scan. A technetium 99 sestamibi scan will be carried out in this patient to differentiate whether it is an adenoma which is causing it or it is hyperplasia which is causing it. So the correct answer is going to be a technetium 99 sestamibi scan. This was asked previously as well. This sestamibi scan has been asked in your exam. A 32-year-old male patient comes with episodic hypertension, headache, sweating and palpitations. What is the most likely diagnosis? Even in these potential question videos which I had shown, I told you that either carcinoid or pheochromocytoma is always asked. This was the question stem for pheochromocytoma, where you know episodic hypertension, headache, sweating, these are the features. In a young patient, if the patient is coming with these are features of pheochromocytoma. And to confirm pheochromocytoma, we will do plasma-free metanephrines. That will be the test to confirm the diagnosis. Screening test is 24-hour urinary VMA. That is the screening test. So 24-hour urinary VMA is the screening test, whereas plasma-free metanephrines will be the diagnostic test which will tell us the diagnosis of pheochromocytoma. For carcinoid tumors, we are going to do urinary 5-hydroxyindole acetic acid. Okay, that is what we are going to do for carcinoid tumors, which is not a superior mediastinal tumor. So mediastinal tumors, superior mediastinum, thyroid can be there, thymus can be there, right? We know that thymomas are the most common mediastinal tumors overall. Okay. Parathyroid tumors can also be there in the superior mediastinum. Leukemias are not seen. Sometimes lymphomas can be seen, but not leukemias. Okay. And if lymphoma was there in the option, then also you would mark that, because it is uncommon in the superior mediastinum. Lymphomas are usually seen either in the anterior or the posterior mediastinum. You should also know the most common mediastinal tumor in children. The most common mediastinal tumor in children is a neurogenic tumor, and this is usually seen in the posterior mediastinum. A 50-year-old male with a history of tobacco chewing presents with a whitish lesion over the buccal mucosa since 6 months. So there is a history of tobacco chewing, there is a whitish lesion. We know these whitish lesions are known as leukoplakia. Now, if you have a leukoplakic patch in a patient who is a tobacco chewer, it has been persisting for 6 months, we will always do a biopsy to rule out cancer in that condition, because we know that leukoplakia is a pre-malignant condition which can get converted into cancer. So what will be the next step in the management? Of course, you will ask the patient to avoid smoking, but we don't do wait and watch. We will do a local excision and biopsy to rule out cancer in these patients as well. They had given one of the options was steroid injection. Steroid injection is not used in leukoplakia. It is used in a condition known as chronic submucous fibrosis, which can also occur in patients who are tobacco chewers, and this is the one which can also increase the risk of cancer, but in those patients we use local triamcinolone injections. A 50-year-old lady is diagnosed with papillary thyroid cancer and undergoes thyroidectomy. So papillary thyroid cancer we know is the most common thyroid cancer. The patient has undergone a thyroidectomy and she comes to you for second opinion after the procedure. What would you recommend? So if you remember the treatment of thyroid cancers, we have discussed that differentiated thyroid cancers, once the surgery has been done, we will do a radioiodine scan. And why are we doing the radioiodine scan? We are doing it to look for residual disease or for metastatic disease. So if you see the flow chart, once the surgery has been done, then we wait for 4 to 6 weeks and we will do a whole body iodine scan. This whole body iodine scan tells us about residual disease or metastasis. And if residual disease or metastasis is present, then we will carry out radioiodine ablation, which is iodine 131. And another question which has been asked is that the half-life is 8 days and this acts via beta rays. So that is what you should know regarding the follow-up in a patient with papillary thyroid cancer after surgery. These were the questions regarding head and neck, thyroid and endocrine system. Moving on to the questions from GIT. So which of the following components are correct components of child PUG score? Now child PUG score is an important score and they had given various options which had various permutations. The correct answer here, child PUG score, has 5 things: albumin, bilirubin, PTINR, ascites and encephalopathy. These are the 5 things which are included in the child PUG score and you need to know this for future exams as well. So child PUG score, encephalopathy, ascites, bilirubin, albumin and prothrombin time or INR. Each value is given a score from 1 to 3. So the minimum score is 5 and the maximum score is 15. If it is child PUG A, that is 5 to 6, that means least severe liver disease and you have adequate functioning liver present. B is moderate 7 to 9 and C is severe 10 to 15, where remnant liver tissue or functional liver tissue is hardly present, and that is decompensated liver disease. A 32-year-old patient undergoes an emergency laparotomy for perforation. So they've mentioned that it is an emergency laparotomy for perforation, right? So after this, they are asking which is the sure shot sign for wound dehiscence. Now, if you remember your lecture on general surgery, the causes of postoperative fever, I have told you on postoperative day 6, usually there can be a burst abdomen. The rectus sheath can open up, and that is known as burst abdomen or abdominal wound dehiscence. Now, abdominal wound dehiscence, how do we know wound dehiscence has occurred? There will be copious serosanguinous discharge. This is also known as Salmon fluid sign or serous fluid sign. Large quantities of reddish fluid is going to come out, and that tells us that the rectus sheath has opened up and the bowel is coming out of the wound. That is abdominal wound dehiscence, and in such a situation the emergency management is urobag laparotomy. A homosexual man complains of defecation, painful defecation and a mass protruding from the anal canal. On biopsy, diagnosis of squamous cell carcinoma of the anal canal is made. So, homosexual man, human papilloma virus, all these are risk factors for squamous cell carcinoma of the anal canal. This question was quite frequent in the PG exams and the FMGE exams a few years back. So, it's made a comeback after a gap of a few years. And the treatment for squamous cell carcinoma of the anal canal is known as Nigro's regime, which is combined chemoradiation. So, you're going to give chemotherapy and you will give radiotherapy as well. Chemotherapy is usually 5-fluorouracil and mitomycin C, and radiotherapy is also used. So this combined chemoradiation for anal cancers is known as Nigro's regime. Endocrine tumors of the pancreas was asked last time also, this time also. They just keep on changing. Last time they asked about, they had asked about a gastrinoma. This time they've asked about a glucagonoma. So you had a diabetic patient with DVT and a necrolytic migratory rash. Okay, so diabetes, dementia, DVT and a rash, these are classical features of a glucagonoma. Okay, so insulinoma is the most common pancreatic endocrine neoplasm, equally distributed. 90% patients have benign tumors, and the patient comes with Whipple's triad, that is fasting hypoglycemia, sugar less than 40 and rapid resolution on giving glucose. The gold standard test here is 72-hour fasting test. Gastrinomas, they arise from the G cells, also known as Zollinger-Ellison syndrome. 70 to 80% are malignant, and most of the gastrinomas arise from the gastrinoma triangle. This has also been asked in the exam. The gastrinoma triangle or the Passerose triangle is formed at the junction of the cystic duct with the CBD, second part with third part of duodenum, and junction of head and neck with the body of pancreas. Majority of the gastrinomas lie within this triangle and mostly arise from the wall of D1. Glucagonoma, 4Ds, diabetes, dermatitis, DVT and depression, and you get a classical necrolytic migratory rash as was asked in the question. Idiopathic hypertrophic pyloric stenosis or congenital hypertrophic pyloric stenosis is a constant question in all the exams, and this was no surprise that it was asked in the FMG exam as well. They had asked which is not true regarding idiopathic hypertrophic pyloric stenosis. Presents with non-bilious vomiting. This is true because the hypertrophy or the obstruction is before the duodenum, so it does present with non-bilious vomiting. It is caused not by hypertrophy of the longitudinal muscle, it is caused by hypertrophy of the circular muscle. That is what leads to idiopathic hypertrophic pyloric stenosis. Ultrasound is very sensitive. Yes, thickness of more than 4 millimeters and the length of the pyloric channel more than 16 millimeters is quite sensitive in diagnosing this condition. And hypokalemic, hypochloremic metabolic alkalosis with paradoxical aciduria is seen in this condition. This has also been asked many times. So this was a straightforward question. We know the investigation of choice is ultrasound, thickness more than 4 millimeters, length more than 16. You can get a single bubble sign, and if you do a contrast study, you can get string sign, double track sign, or mushroom sign. Males are more commonly affected. Patient comes with non-bilious vomiting, there is visible peristalsis from left to right, and the best time to examine the patient is during feeding. The management, we know that first we have to correct the dehydration, give fluids to these patients, and we either use 0.45% normal saline or ringer lactate, and the surgery carried out is Ramsted's pyloromyotomy. Again, a straightforward question. An alcoholic patient presents with epigastric pain radiating to the back. Amylase is raised. What is the diagnosis? I think so it's straightforward. It is pancreatitis. Most common indication for splenectomy is ITP, idiopathic thrombocytopenic purpura. In these patients, there are autoantibodies, platelet counts are low, and splenectomy is usually done to boost the platelet counts. So this is the most common indication for splenectomy, which you should know about. Of course, if trauma is also mentioned, then you will mark trauma as the answer. But here trauma was not there, so ITP will be the correct answer. There were two questions regarding hernias. They were reasonably easy questions. A patient presented to the surgery OPD with a reducible mass in the left inguinal region. Cuff impulse was present. So they've said cuff impulse is present and a diagnosis of inguinal hernia was made. Some students were saying that it was indirect inguinal hernia which was given there. Irrespective whether it is indirect or direct, they had asked the surgical management, and we know that the best surgical management for hernias is hernioplasty, not herniatomy. Herniatomy is done in children, and when there are congenital hernias, that's when we do herniatomy. Hernioplasty is when we are using a mesh, and that is the treatment of choice. We carry out a Lichtenstein's tension-free mesh hernioplasty. This one was a slightly tricky question. Which of the following structure of pelvis will have recurrent hernia? The answer is short and wide. Question which has not been asked in any previous exam, and difficult to get the reference as well. But short and wide would be the best option to go for. And salivary glands. Moving on to vascular system. So vascular system, the important topics are DVT. DVT, you should know the diagnosis. You should know the prevention. I have already covered in the first video pneumatic compression stockings and low molecular weight heparin, which is used for prevention. From arterial disorders, so for varicose veins also, varicose veins, you should know about the signs of varicose veins, and you should know about varicose ulcer. You should know about Marjolin's ulcer. Marjolin ulcer, 2 times this has been asked. I'll cover up what Marjolin's ulcer is also. Arterial system, you should know about acute and chronic arterial occlusion, and you should know about Raynaud's phenomena. So acute and chronic occlusion and Raynaud's phenomena is asked frequently in the exam. Claudication and Raynaud's phenomena, almost every year they are asked. So male patient, hints are male patient, smoking, patient comes with blackening of index finger. So this is one of the causes of chronic arterial occlusion. It is known as Berger's disease. Berger's disease, males are more commonly affected, and smoking is a major risk factor there. 50-year-old female underwent an orthopedic surgery of the lower limb, after which she was bedridden for 3 days. So let's see the hints. Orthopedic surgery, lower limb, bedridden for 3 days. Suddenly she develops breathlessness. So what has happened? Because she was bedridden after a lower limb surgery, she's developed DVT, and after DVT she has developed pulmonary embolism. So the answer is venous thromboembolism. Fat embolism we know will occur 48 to 72 hours after long bone fracture. No such history is mentioned here. There is no long bone fracture here. Okay. Air embolism, no IV line has been inserted, no risk of air embolism. Okay. So the answer here is DVT and pulmonary embolism. CEAP classification, this was asked 2.5 years, 3 years back in the FMG exam. Since the last 2 years, this question has not been asked. The CEAP classification has not been asked. Yes, questions from varicose veins have been asked, but not these CEAP questions. So if you can remember the staging, excellent. If not, just remember the images of the various signs which I will show you. So the correct answer here is C2A. This is the staging. C2 are varicose veins, C1 are telangiectasic or reticular veins, C3 is edema, C4 are skin changes. Usually these skin changes signs are as lipodermatosclerosis, pigmentation and corona phlebectasia. C5 is an active ulcer, C6 is a healed ulcer. So these are known as thread veins or telangiectasic veins. These are less than 1 mm. These are thread veins which you should know about. This is corona phlebectasia. Corona phlebectasia is when you have multiple thread veins or multiple telangiectasic veins around the medial malleolus. This is known as corona phlebectasia. This is an image of atrophy blanche. Atrophy blanche is also an early sign of advanced venous disease. This is known as atrophy blanche. This has been asked in the FMGE exam. This you should know. This is lipodermatosclerosis. In lipodermatosclerosis, the fat obliterates and the image of the limb, it becomes like an inverted champagne bottle. So this is inverted champagne bottle appearance which is seen in lipodermatosclerosis. Now a patient undergoing coronary artery bypass grafting, the great saphenous vein is harvested. So for coronary artery bypass grafting, we use the great saphenous vein. Now when the great saphenous vein is harvested, which nerve can be injured? So for great saphenous vein, it is the saphenous nerve. Always remember, great saphenous vein, it will be the saphenous nerve, and if it is short saphenous vein, it will be sural nerve. This has also been asked in multiple exams. This question was asked last year, last to last year, and repeated last year as well. A patient comes to the emergency with severe hand pain. Emergency doctor notices the following changes in her hand. So you can see white, blue, red. The sequence of events is white, blue, red. So we are dealing with Raynaud's. In Raynaud's, the change is white, blue, red. Whether it is primary Raynaud's or secondary Raynaud's, that is what you had to decide. So the correct answer here is primary Raynaud's. Why is it primary Raynaud's? Because primary Raynaud's is more common as compared to secondary Raynaud's. And secondary Raynaud's is usually associated with collagen vascular diseases like SLE, rheumatoid arthritis. No such history was mentioned there. Okay, and primary Raynaud's is most common. You should also know that the drug of choice for Raynaud's that has also been asked is calcium channel blockers. Are calcium channel blockers. Very important question. This has been asked multiple times in the exam. A patient having burns 10 years back. So burns 10 years back now presents with ulceration over the same area. So burn scar, long-standing burn scar or venous scar, if there is ulceration now, this is a Marjolin's ulcer. Marjolin's ulcer, you can see if the image was shown, if you're shown an ulcer in the region of a scar, this is a Marjolin's ulcer. It is usually a squamous cell carcinoma. Okay. Again, a frequently asked question in all FMG and PG exams. A patient comes with a history of smoking with cramping gluteal pain after walking 500 meters. Which vessel is involved? So in any question, if you're told that pain comes after walking a certain distance, this is known as the pain of intermittent claudication. Okay, this is known as the pain of intermittent claudication. And if it is involving the gluteal region, then aortoiliac involvement means the block is at the aortic bifurcation. This is known as Leydig syndrome. So if the block is at the aortic bifurcation, it is known as Leydig syndrome. Patient, the earliest sign is going to be gluteal claudication, and male patients can also come with impotence. Okay. A lady with atrial fibrillation. So this is the hint. Atrial fibrillation comes with sudden occlusion of the lower limb. So whenever there is sudden occlusion of the lower limb, you get 6 P's. Pain, pallor, pulsionosis, paralysis, poikilothermia. Poikilothermia is the limb becoming cold. And paresis. Paresis means weakness. The most poor prognosis would be when paralysis. If paralysis develops, that is a poor prognostic feature in sudden arterial occlusion. And if there is sudden arterial occlusion, we need to carry out an embolectomy in these patients. Patient undergoes prolonged surgery and is bedridden. Surgeon examines the lower limb and is found to have Homan sign positive. What is your diagnosis? So again, prolonged bedridden patient, DVT, deep venous thrombosis. We've discussed this. DVT, most common symptom is pain, most common sign is lymphedema. And it is usually unilateral. Okay, it is usually unilateral. Please remember that. There are two clinical signs, but we should not do these clinical signs. They are mainly of theoretical importance. Homans is pain when you carry out dorsiflexion of the foot, and Moses is when you squeeze the calf, there is going to be pain. The investigation of choice for DVT has also been asked. It is duplex or Doppler scan. Now, invariably in all FMG exams in the last 3 years, I've seen one image of an ulcer being asked. Whether it is basal cell carcinoma, whether it is venous ulcer or Marjoline's ulcer or arterial ulcer, one image of an ulcer is definitely asked. So I want you to be well versed with all these images of ulcers and how to diagnose them. This one is typically a venous ulcer. Let's look at the features of a venous ulcer or a varicose ulcer. So varicose or venous ulcer is usually formed in the region of the medial malleolus or the gaiter area. That is the region where this is formed. It is a shallow ulcer with sloping edges and you have pale granulation tissue and pigmented margins are there. Arterial ulcer on the other hand, what are the key points which we need to look at in the question? We need to look at absent pulsations. So in the question stem they'll mention absent pulsation, punched out edges, shiny skin, loss of hair, loss of muscle mass. These are the things which we need to look out for. Trophic ulcer. Trophic ulcer is formed when there are no sensations. There's loss of sensations. So supposing in diabetic patients, loss of sensations are there. So it will be a punched out ulcer, which will be a non-healing ulcer. It won't heal. And the most common site is the sole or the ball of the great toe. So this is also a diabetic ulcer, which is an example of a neuropathic ulcer. Tubercular ulcer, the classical finding is undermined edges are there. So tubercular ulcer, you are going to get undermined edges. Okay. Basal cell carcinoma and squamous cell carcinoma. So squamous cell carcinoma, you will have raised, everted, cauliflower-like edges. Basal cell carcinoma is also known as rodent ulcer. Very, very, very important. This is the most common skin cancer which is asked, and one question from skin cancer is definitely there in all FMG exams. So a lady comes with a growth over the side of the nose. What is the likely diagnosis? It is a basal cell carcinoma. So basal cell carcinoma is also known as a rodent ulcer. Most common site is the face, above the line joining the angle of the mouth and the ear lobule. Right? This is locally invasive, but it does not metastasize. Rarely goes to the lymph nodes as well, and we need to carry out wide local excision. So you should be able to identify a basal cell carcinoma. I've already told you the features of basal cell carcinoma. I have a 39-year-old lady. She comes with features of heat intolerance, weight loss. On examination, the right lobe of thyroid. On examination, the right lobe of thyroid reveals a 2 into 2 centimeter swelling. TSH is low. What is the next step in the management of this patient? So this patient has features of hypothyroidism or hyperthyroidism? Hyper, correct. Hyper and low TSH, what will we do first? We will do thyroid scan. We will do a thyroid scan in these patients. Okay. So this thyroid scan, what does it depict? Correct. This is plumber's disease. Plumber's disease or toxic nodular goiter. You can see multiple hot nodules. This is plumber's disease or toxic nodular goiter. In Zuska's disease, you will prefer Hatfield's procedure. Whomsoever asked that question in Zuska's, you will prefer. Yes, in Zuskas, we'll do Hadfield's procedure. So this is a normal thyroid scan. What are the abnormalities in a thyroid scan you should know about? So you should know about a cold nodule and a hot nodule. Cold nodule, you can see that the entire gland is taking up the contrast, but this one particular nodule is not taking up any contrast or any iodine. This is a cold nodule or a non-functioning nodule. Correct, non-functioning nodule and cold nodule have higher risk of cancer. 20% can be cancerous. Hot nodule, this is a hot nodule or a hyper-functioning nodule. This is a solitary toxic nodule. Okay, so hot and cold, I've told you. This one is toxic nodular goiter, where you can see multiple hot nodules. This is toxic nodular goiter or plumber's disease. Okay, I will just tell you, Ishan, and let me just tell you about thyroid investigations. Just 1 second, I'll tell you about thyroid investigations. How do we go? So please remember, the first investigation in thyroid is always thyroid function test. That is the first investigation in thyroid. The investigation of choice in thyroid is FNAC, is fine needle aspiration cytology. If TSH is low and hyperthyroid features are there, then we will do a thyroid scan. This we've already discussed. Which isotope is used for thyroid cancer management? Iodine 131. That is correct. 131, and it acts via which rays? Beta rays. No, guys, beta rays. Acts via beta rays. And half-life is 7 to 8 days. Very important slide. This is also frequently asked. So either papillary carcinoma thyroid slide is asked or medullary carcinoma thyroid slide is asked. Papillary carcinoma, you will see orphan aniide nuclei, or you will see samoma bodies. So papillary thyroid cancer and medullary thyroid cancer slides are very important. So you can see orphan aniide nuclei here, and this is papillary thyroid cancer. Which is the most common thyroid cancer, and it has the best prognosis. Again, you can see a better slide of papillary carcinoma thyroid, where you can see orphan aniide nuclei. Medullary thyroid cancer, I don't have the slide, but medullary thyroid cancer, you will see amyloid-rich stroma. In medullary thyroid cancer, you will see amyloid-rich stroma. So this amyloid will be visualized as pinkish material. So they will give you a question that an FNAC is done, and you will see this pinkish material on a slide. Which cancer are you dealing with? You're dealing with medullary carcinoma thyroid, and calcitonin, yes, is a tumor marker for medullary carcinoma thyroid. A patient with a thyroid disorder comes with high TSH and high anti-TPO antibodies, anti-TPO, anti-thyroid peroxidase antibodies, Hashimoto's thyroiditis, correct. So Hashimoto's thyroiditis is the most common type of thyroiditis. It is autoimmune, and here you are going to get antibodies against the thyroglobin, thyroid receptor, and thyroid peroxidase enzyme. A patient comes with diffuse goiter and has raised T3 and T4. Diffuse goiter has raised T3 and T4. What is the diagnosis? Graves' disease. Very good. Graves' disease is correct. So, like I told you, one question will be from complications of thyroid surgery. So a patient undergoes a thyroidectomy, and post the surgery, the anesthetist is unable to extubate her due to persistent cyanosis and airway obstruction. Most probable cause, please. Correct. Bilateral recurrent laryngeal nerve injury. Very good. Bilateral recurrent laryngeal nerve injury. So this is a very important slide, and I want you to remember this slide for your exam. External laryngeal nerve injury is not life-threatening. External is not life-threatening. It will just lead to hoarseness. Patient won't be able to sing in the bathroom, okay? Patient will not be able to sing at a high pitch because of injury to the cricothyroid. Yes, correct. External laryngeal nerve injury is more common than recurrent laryngeal nerve injury. Dave, that is absolutely right. Unilateral recurrent laryngeal nerve injury, hoarseness can be there. Bilateral recurrent laryngeal nerve injury, there can be airway obstruction and stridor can be there in these patients. Very good. Altaf, correct. External laryngeal nerve injury is more common, but mostly undetected. Excellent. These are two signs which are seen in hypoparathyroidism or hypocalcemia. Schwastic sign is when you get a carpopedal spasm, and Trousseau sign is when you get twitching of the facial muscles. This was again asked in your exam. Again, a very important question. Correct. This is a sesame B scan, right? The best is technetium 99 sesame B scan. Technetium 99 sesame B scan is used for localizing parathyroid tissue. The incision which is used for neck dissection is modified Schobinger's incision. Modified Blair's is known as lazy S. This is used for parotidectomy. Stewart's incision is used for MRM. ELN injury, nothing. We just give steroids to see if that is getting better or not. Otherwise, nothing is to be done. Okay. 25-year-old presents with hypertension with profuse sweating and headache. Which of the following investigation should be ordered in these patients? So last time also there was a question from pheochromocytoma in your exams. You should know about pheochromocytomas, urinary VMA and metanephrines. That is correct. So pheochromocytoma, remember please, headache is the most common symptom. Hypertension is the most common sign. It is mostly episodic. The screening test is 24-hour urinary VMA or metanephrines. Most sensitive is plasma-free metanephrines. Okay. You get a tan brown cut surface. MRI is the investigation of choice, and on MRI you will get a light bulb sign. MRI you will get light bulb sign. And extraadrenal pheochromocytoma, you will do a gallium dotatate scan. This is the light bulb sign which you can see in these patients. Again, this was a question which was more of a clinical question, that what is the investigation which you will perform. So mother gets a child with bilious vomiting. The child has bilious vomiting. So we know that if it is bilious vomiting, the block is beyond the second part of duodenum. Okay, so that is common sense. The block would be beyond the second part of duodenum. So we have to see what is the cause. Now, barium enema will tell us about large bowel. So barium enema is out. It will tell me about large bowel. Barium meal can tell me about the stomach and duodenum, but does it delineate the anatomy very well? And in an obstructed system where there's already obstruction, if I give barium, that barium will also become obstructed, right? That barium also will not go forward. Barium swallow is mainly for esophageal abnormality. So the best answer here is going to be CECT. Contrast enhanced CT scan will tell us what is the problem which the child has. Now this was a new question, a new topic which was asked in the exam, that is choledochal cysts. And not one question, but there were actually 2 or 3 questions where they had shown images. Now this time surgery paper was slightly tricky. It wasn't as easy as the previous years, right? And the level of difficulty in the exam paper was also more, which is why you can see that the pass percentage has dropped. So the exam is becoming more and more clinical, and you need to be better equipped for that. So choledochal cyst, they had asked which is a type 3 choledochal cyst. Now choledochal cyst is when there's congenital dilatation of the biliary tree, that is called choledochal cyst. So choledochal cyst type 3 is known as a choledococele. It is known as a choledococele, and it is dilatation of the intraduodenal portion. It is dilatation of the intraduodenal portion, and you can see here this one depicts the intraduodenal dilatation. So type 1 is the most common. This has also been asked, and this is cystic dilatation, or you have cystic dilatation of the CBD, that is type 1. Type 2 is a diverticulum of the CBD. Type 2 is the diverticulum of the CBD. Type 3, I have already told you, is intraduodenal portion or choledococele. Type 4 is intra plus extrahepatic. Intra plus extrahepatic biliary radicals are dilated. And 5 is only intrahepatic dilatation. And only intrahepatic dilatation, this is known as Caroli's disease. This is known as Caroli's disease. Now, the investigation of choice for choledochal cysts is MRCP. Magnetic resonance cholangiopancreatography is the investigation of choice for choledochal cysts, and this can increase the risk of cholangiocarcinomas. It can increase the risk of cholangiocarcinomas, these choledochal cysts. So these are the choledochal cysts which I have just told you. Most common is type 1. I have explained the other types to you as well. And type 4A and 5 are the ones which require a transplant for treatment. This was another image-based question. I felt it was very easy question, but because it was given in an image format, it threw some of the students off guard. So they had asked, what is the preferred incision for appendicectomy? Now we know the incisions for appendicectomy are, what are the various incisions which can be used? So you can use the McBurney's incision, right? And the McBurney's incisions are of two types. You can either have grid iron. Grid iron is muscle splitting incision. Grid iron is muscle splitting, whereas Rutherford Morris is muscle cutting incision. Okay. And another incision which is used is the Lanz incision. So this number 4, this is known as the Lanz incision. This is also known as the bikini incision, and it is a cosmetically better incision. I also have this incision. I was in class 7th when I had my appendicectomy, and I have a Lanz incision which is hidden in the skin crease. So you can't make that incision out. You can't see that incision. A midline incision, this is used for appendicular perforations. A lower midline incision is used for appendicular perforation. So the answer here is going to be number 4, that is Lanz or bikini incision. Now let's look at the other incisions also which have been marked here. Number 1 is a right subcostal incision. This is known as a Cocker's incision. Right subcostal incision or Cocker's incision. This is for open cholecystectomy. This is for open cholecystectomy. Number 2 is a paramedian incision. It is slightly away from the midline, paramedian incision. And number 5 is your Fanon-Steele incision. Is the Fanon-Steele incision. This is used for cesarean sections. Number 5 is Fanon-Steele. This is used for cesarean sections. So you should know these incisions for your exam. Which fluid will you prefer in a patient who's come to the emergency room with profuse vomiting and metabolic alkalosis? So we know this. Let's assume a child who has hypertrophic pyloric stenosis. And in that child, we know what is the metabolic abnormality. You have hypokalemic, hypochloremic metabolic alkalosis, right? Hypokalemic, hypochloremic metabolic alkalosis. And the best fluid in these patients is first normal saline. NS is given, normal saline is given. And you should know the composition of normal saline as well. Normal saline has 154 milliequivalents of sodium and 154 milliequivalents of chloride. Ringer lactate, also the composition has been asked in the FMGE exam. You have 130 milliequivalents of sodium, 4.5 milliequivalents of potassium, 109 milliequivalents of chloride, and you have lactate, 28 milliequivalents of lactate as well. So that is why the name ringer lactate. So in such a situation with profuse vomiting, we will use normal saline, right? Now normal saline, ringer lactate and dextrose are crystalloids. These are examples of crystalloids, whereas albumin is a colloid. Albumin is a colloid. Okay. A chronic alcoholic patient with liver disease presents with melena and hematemesis. What is the most likely cause? So the patient is having upper GI hemorrhage. Hematemesis means blood in the vomitus. And because there is blood in the upper GI, you are getting black tarry stools as well. That is called melena, right? Now, what are the various causes of upper GI hemorrhage? Varices can be there, Mallory Weiss tear can be there, Boerhaave can be there, duodenal ulcer. So all are causes. Now, the hint which they've given is that this patient is chronic alcoholic. So in chronic alcoholic, right, you can get Mallory Weiss tear, right, which can occur because of splitting of the mucosa and the submucosa. But more common in these chronic alcoholic patients will be esophageal varices. Okay, so varices will be the best answer here, and the hint is chronic alcoholic patient. That is why esophageal varices would be a best answer. Now, Boerhaave syndrome is perforation, right? So esophageal perforation can be of two types. You can either have iatrogenic perforation or you can have spontaneous esophageal perforation. Iatrogenic perforation is after endoscopy, right? You do an endoscopy and the esophagus perforates. This is more in the upper 1/3, and usually these patients are stable and they don't require surgery, right? So majority are small stable patients. You do conservative management in these patients. That means you will make the patient nil per oral, give IV fluids, IV antibiotics and analgesics. Spontaneous esophageal perforation is called Boerhaave syndrome. This has also been asked frequently in the exam. This perforation occurs after forceful vomiting, and this commonly occurs in the lower 1/3 of the esophagus, the left posterolateral wall. And you should know about the Mackler's triad in spontaneous esophageal perforation, that is retching, chest pain and surgical emphysema. This has also been asked in the exam. This is a Mallory Weiss tear. A Mallory Weiss tear, I told you, is a split in mucosa and sometimes submucosa. This is also seen in alcoholic patients, common in alcoholic patients after vomiting. And usually the bleeding is self-limiting. In Mallory Weiss tears. Now, a patient underwent this surgery a few months back, and he complains of dizziness, headache, sweating 40 minutes after consumption of food. So you can see here that this patient has had a bariatric surgery. Okay, this patient has had a bariatric surgery, and this is a Billroth reconstruction. If you remember your classes, I've taught you about Billroth reconstruction, right? So this Billroth reconstruction, this can give rise to dumping syndrome. And headache, sweating, tachycardia after 40 minutes, these are all signs of late dumping. Okay, these are all signs of late dumping. So let's read about dumping syndrome. Now, dumping syndrome can be of two types. You can either have early dumping or you can have late dumping. Early dumping occurs when more fluid comes into the bowel as soon as the patient eats food. And when that happens, the patient is going to have bloating, nausea, vomiting, right? Those will be the features, and they will occur almost within 10 to 15 minutes of eating food. And also, if the patient eats more food, there will be more bloating and more vomiting. Late dumping, on the other hand, you should know it occurs because of rebound hypoglycemia. So more insulin is secreted, and that can give rise to rebound hypoglycemia. That is why the features are headache, sweating, tachycardia. Now this will improve with more food, and these symptoms usually occur after 30 to 40 minutes. Now, because they've started asking about dumping syndrome, you should know how do we prevent dumping syndrome. So we can prevent dumping syndrome by small frequent meals, by avoiding liquids with meals, by avoiding simple sugar and sugar-rich liquids, and in resistant cases, we can use octreotide as well. We can use octreotide as well in these patients. Now, what is the most common complication after bariatric surgery? So this was a very straightforward question. The most common complication following bariatric surgery is iron deficiency anemia. And even last year, there were 2 questions in the last FMG exam from bariatric surgery complications. One was regarding iron deficiency anemia. The other one was regarding vitamin B12 deficiency. So iron deficiency is the most common nutritional deficiency following bariatric surgery. Vitamin B12 deficiency can also occur, but this will give rise to megaloblastic anemia. So that was what was asked last year. This is going to give rise to megaloblastic anemia. Calcium deficiency can also be seen. Protein energy malnutrition is only seen in certain types of bariatric surgeries like duodenal switch, and BPD, that is biliopancreatic division. Not in all bariatric surgeries you will not see protein energy malnutrition. Very simple, and this was a very I would say a common sense question which was asked: what advice would you give to a patient who's being planned for laparoscopic cholecystectomy? So this time the questions were very clinically oriented, lots of questions from GIT, and they were very practical questions. I mean, even if you haven't read, but if you've gone to the ward, if you know how a patient is prepared, you can answer a lot of questions. So patient is planned for laparoscopic cholecystectomy. What advice will we give to the patient? Eat full before surgery? No, we don't want to do that. Drink plenty of fluids? No. Enema at night? So we are not doing a bowel surgery, right? So if you are not doing bowel surgery, why do we want to give enema, right? Avoid solid foods for 6 to 8 hours before surgery. That is correct. This is correct. Water, sips of water you can take up till 2 hours before as well. Sips of water can be taken up till 2 hours before as well. Clear liquids can be taken up till 4 hours before as well. Clear liquids can be taken till 4 hours, water till 2 hours, but solid foods we need to keep the patient fasting for 6 to 8 hours. A 16-year-old male comes with bronchospasm. On investigation, the tumor is found in the ileum and has increased 5-HIAA. What is HIAA? 5-hydroxyindole acetic acid in the urine. So what is the diagnosis here? The diagnosis is going to be carcinoid syndrome. We know in carcinoid syndrome, serotonin is released, and serotonin, once the serotonin gets metabolized, it can come out as 5-hydroxyindole acetic acid in the urine, and this is what we can use to identify it. The most common site for carcinoid tumors is the appendix. This has also been asked in the exam. Now, another common sense question which was asked was: a male patient comes with 3rd degree burns to the neck and the lower back. Now we know 3rd degree burns, we have to do early debridement. But before doing debridement, burns patients are dehydrated. So before you do debridement, you have to first resuscitate and then do the debridement. Okay. So they had given what will be the correct order in the management. So first will always be resuscitation. So these 2 options are out. Now after resuscitation, we will do debridement and then we will do grafting. Now some students said that there were 2 separate options. There was autograft and allograft. Some said that it was the same option. Now if there were other options, autograft will be the best answer, right? Because we will take skin from the same patient and we'll put skin there. So that is known as autograft. Okay, that is known as autograft. If you take skin from the same patient and put it at in the body of the same patient, it is autograft. That is the best in burns. But if both of them were clubbed, that is the best answer. If not, then you will mark autografting. Okay, another question which was asked, a patient gets run over by a tractor and is brought to the emergency room after 2 days. So this is important. The patient comes after 2 days, right? After 2 days, the patient has come after delayed presentation and there is extensive injury. So there is degloving injury which you can see in the image. And you can see that the muscle is not very healthy looking. It is looking like dead, right? Not healthy muscle. So what do we do in these patients? Amputation? No, it is still viable. There's no gangrene. Debridement with primary closure? No, the patient is coming after 2 days. And if you do a primary closure, there is a chance that there might be an infection there. Flap closure? Again, flap closure is also a type of primary closure only. If a patient is coming late, we will avoid a primary closure because that can lead to infection then. Okay? So that is why after elimination also you could have reached the answer of debridement and hyperbaric oxygen. Now hyperbaric oxygen can be used if you have an element of necrotizing fasciitis, right? If you have an element of necrotizing fasciitis which can develop after trauma like these as well. So you will have to debride thoroughly, means cut off all the dead tissue. Debridement means cutting off all the dead tissue and then do hyperbaric oxygen. A patient suffering from Raynaud's disease. So this was a question from vascular surgery. A patient suffering from Raynaud's disease presents to the ER with change in color of the fingers from white to blue to red. Which drug would you recommend? So this is calcium channel blockers. This has been asked previously as well. So in Raynaud's, you know the sequence of events, how it changes is white, blue, red, And primary Raynaud's is more common as compared to secondary Raynaud's. This was a question which was asked last year in the exam. Primary Raynaud's is more common and primary Raynaud's is not associated with collagen vascular diseases or autoimmune diseases, right? Primary Raynaud's is usually not associated with collagen vascular diseases or autoimmune diseases. Okay. Another question from vascular surgery, a chronic smoker complaining of cramping pain and walking 500 meters, gradually the distance at which he experiences pain reduces to 200 meters. And over the next few months, he starts experiencing pain at rest as well. So gradually the distance is reducing, and gradual reduction in distance and this cramping pain, these are classical features of vascular claudication, okay? Or this can be seen in Berger's disease, in atherosclerosis, where gradually the distance keeps on reducing. Neurogenic claudication is because of lumbar canal stenosis, and this can change with posture. It will change with posture. This pain will vary. Osteoarthritis pain, it is worse when patient takes first step. That is what leads to the worst pain of osteoarthritis. So another question from vascular surgery, LAD, left anterior descending artery, coronary artery disease. Which is the graft which will give the best results? So great saphenous vein is the most commonly used graft material when we have to do a CABG. What is CABG? Coronary artery bypass grafting. When we have to do, then great saphenous vein is the most common. But for left anterior descending artery, left internal mammary artery will give the best results. So these days the best results are coming with internal mammary artery grafts. So great saphenous vein is the most commonly used, and a question which was asked last year in the exam, which nerve can be injured while using this graft? So the nerve injured can be the saphenous nerve. Is the saphenous nerve. This was asked last year in the exam. And Lima Lad, I've already told you.